Okay, I can start.
So I would invite Dr. Aurora for his talk. Dr. Aurora, please, will you share your screen and...
Okay, I'll do that. Can you see my slide?
Yeah, Dr. Aurora, your voice is clear, your slides are visible.
Thank you.
And I invite Dr. Aurora to talk about macular hole management. Dr. Aurora, please go ahead.
Right. Thank you. And it's I thank Janta Pharma and Ordinary Surgeon Society for giving me this opportunity of to present my work on macular hole current concepts in retina and glaucoma. So I think it's 15 minutes, no? Yeah. So essentially, macular hole could be either idiopathic, which is the most common, or it could be traumatic. And whenever we examine a patient with a macular hole, these are basic pre-op examinations which we need to do: a good slit and a biomicroscopy, looking at best corrected visual acuity, metamorphopsia, Amsler, SDOCT, good evaluation of retinal periphery, and overall general examination to assess whether the patient can lie face down. The best predictor of macular hole success is the starting visual acuity, shorter duration of symptoms, smaller macular hole. The stage 1 macular hole may close spontaneously, but the holes greater than stage 2 need to be operated. This was what Dr. Gass had proposed, the classification of macular hole, and he did it all together without the OCT, just on pure clinical examination. The OCT has not really improved much upon Dr. Gass's observations. So we have holes from stage 1 to stage 4. The stage 4, there is a complete PVD. The international classification was put forth in 2013, and the holes have been classified into small holes, medium are less than 400 microns, and large are more than 400 microns. And I suppose many people believe that holes which are more than 800 microns could be labeled as ultra large. Chun et al. Believe that small holes should be 250, and between 250 to 600 or 650 should be the medium holes, and above that should be large holes, because the holes up to 650 behave in a similar manner. Now, how do we treat these macular holes? One is spontaneous closure. This is when the hole is about 50 to 100, this not 10, is 100 microns without a vitreomacular adhesion, about 2.7 to 8.6% is closed. Ocriplasmin, which is actually very expensive. So I have not personally used it, but it is it's available. It's not really picked up because of the expense. And it can be used in selected cases of holes which are less than 400 microns with a closure in about 40% cases versus 10% cases where any injection would work as a placebo. Now, most cases would require a vitrectomy, and essentially in vitrectomy, we remove the entire hyaloid posteriorly, either by dilutive fluorescein, which used to do long time back, but now we use Transferlon. And then we do various techniques of eyelid peeling, which I'll be discussing subsequently, followed by a gas tamponade and rarely oil tamponade. So it would either be SF6, C2F6, or C3F8 isofluoropropane and a phase down position. Now, macular OCT, we can have an intra OCT, which improves your skills, but I don't have an access to an intra OCT, but nonetheless, the macular hole surgery technique remains the same. The other options are neurosensory graft, arcuate retinotomy, radial incisions, and in cases of posterior staphyloma, a macular buckle. Now, how do we handle ILM? We can either do an inverted ILM flap, which was described by the Nowaroki group, a petaloid or a cabbage closure. The cabbage closure was described by us and published in 2016. Then you have a free ILM flap, especially in recurrent macular hole, or we can use lens capsule, amniotic membrane, or an autologous neurosensory retinal graft. So this was described by Grewal and Mahmood, in 2016, where they took a patient who was a refractory macular hole and a free neurosensory graft was put, which showed a microperimetric improvement in patient's visual acuity and from 20 by 200 to 20 by 80 in 3 months' time. And this is really picked up, and a lot of people are doing it. Now, this technique has not really picked up, where you make a arcuate retinotomy, which the authors described in 6 patients, and they had success in about 83% patients, where you create a full thickness this thing with a 25 gauge scissor. The retinal flap is mobilized with a soft tip, and it makes the whole oval and eventually closes. Or you can make these 5 perifoveal radial incisions, starting 1 disc diameter away from the hole and moving towards the center, and then you move the flaps with a soft tip. Now, before we peel the ILM, we have to use dyes to be able to identify the ILM, and various options are available. Most often in India, we use brilliant blue green or an ICG, and I'll be sharing that with you. So this is a small study we did, and this is about, the data is still about 3 years back. There were about 33 eyes where we had macular holes varying from 494 to 1100 microns, 30 holes closed, 3 remained open. There was type 1 closure in 26 and type 2 closure in 4 eyes. These are some of the examples of the hole closure. You can see here beautifully pre-op and post-op, the holes have closed well. And most of our cases, we are using the cabbage technique, which I will show you. This is again a patient where ERM was there, with a pass-through navigation ERM with the fluorescent thinning, and patient did well. Now, whenever you have a large macular hole, we have to have a large inverted flap, and there are various techniques that have been described. One of our technique is to use a cabbage closure technique. And we have now about 6 cases varying between 808 to 1200 microns. And I'll share with you the video of the case and how we did it. So these are various indices which we normally record in our patients. And this is just to show you the video. So this is a 25 gauge vitrectomy. We put in the infusion ports. We put in the other ports and a chandelier, and a vitrectomy is done where if you can see the vitreous very well enough, I can identify the posterior hyaloid. I may not use triamcinolone, but triamcinolone gets absorbed to the vitreous surface, and it actually helps in visualizing the posterior hyaloid. So now the hyaloid has been lifted up, ICG staining has been done, and we create this flap. You can see here a flap is being created. So this flap is inverted over the macular hole, and it is left like that. So please notice here, each flap will have a retinal surface and a vitreous surface. Now this is important. I'll explain to you why this is important. So we can create 3 to 5 flaps, and supposing sometimes you may lose 1 flap also, it doesn't matter, because you have enough number of flaps to cover the entire large macular hole pretty well. So the staining with the ICG is very good, and the last flap is the third flap is being made. We'll make 1 more flap after this. So the reason why I said vitreal and retinal surface is important, because we did some EM studies on the ILM, and we found that the surface configuration of the ILM on the vitreal surface and retinal surfaces are different. And if you place the retinal surface over the vitreous surface of a previous flap, it will stick to it like a Velcro. So this is how we have created these flaps. If the flaps are large, you could actually trim it, or you can leave it, and generally the hole closes, and these flaps gradually are not visible subsequently. You can see them for some time on the OCT, but subsequently they really do not cause any issue. But sometimes when you try to cut them, you might end up by removing the entire flap. So we have done the entire surgery, put in gas, and so let us see. This is the patient. She was a 61 years female with blurred vision of one eye. This is her anterior segment status. The left eye visual acuity was 6 by 36. This is the pre-op OCT. This is the Octa slabs at the ORCC as well as at the superficial slab. And this is the post-op situation. The visual acuity had improved. The macular hole had closed, and you can see the ILM flap lying on the macular hole. The ORCC slab, if you look at the previous month, you find that you find this highly reflective thing on the ORCC because you can see the RP, but that is all closed and the macular hole is closed here. So this is the pre-op and this is the post-op, and patient had come recently. Patient visual acuity had improved to 612. We have to wait for almost 6 months to 1 year sometimes to get the final best corrected visual acuity. This is another patient where this was the first time when we did a cabbage technique. This was this was a male patient who had come. This was post cataract surgery. This was a large macular hole pre-op, and we had that time used BBG for this. Used the cabbage technique. There were 3 flaps inverted and trimmed and put securely over the macular area. This is the OCT 3 weeks subsequently. This is 3 and 14 weeks, and you can see glial tissue growing and bridging the macular hole. Surprisingly, this patient's visual acuity had improved significantly, and he from a level of 360 had come to 6 by 24. So he's doing well, and after we operated his this eye, he actually got his other eye to got operated. So what is the rationale of a surgical technique? It's very important to have a well-stained ILM so that it can depict around the macular hole, divided into multiple leads like the cabbage, and put over the macular hole. As I said, there's a vitreal surface and there's a retinal surface. When you put these flaps over each other, they sort of stick to each other like a Velcro. And once they're juxtaposed, they close the macular hole like as a closed chamber. So I believe that this closure actually generates centrifugal forces on the edges of the macular hole, and this may contribute towards the closure of the macular hole. Also, this creates a closed space and activates the RPE pump, which may become active in a closed space, aiding in the hole closure. It is critical to spend some time on the table before and after the fluid gas exchange to ensure that the ILM flaps are well juxtaposed, they are attached to each other, and once they get well attached to each other, they will not move out, and the chances of your failing are very little. So this is just to sum up, good staining of the ILM. We do a complete vitrectomy, remove the highlight, well-made ILM flaps, fluid gas exchange, tone positioning. I generally ask my patients to lie face down for about 10 to 12 hours, at least for a week. We tell them about 12 days, but most of the patients here in our country, if you tell them 12 days, at least they'll do for a week's time. So we do that, and that has worked really well. Thank you for your attention, and I hope there is a take home for you. And if this technique really works well in my hands, I'm sure if you do it well, it's going to work well for you.